The Katz Index measures the ability to independently perform activities of daily living in the following areas: bathing, dressing, toileting, transferring, continence, feeding.
Unfortunately, I don't think most healthcare providers understand how devastating functional decline can be for an older adult. It can be very precipitous. We see many older adults who come into a hospital and who, with a few days in bed, can no longer return to their home. So they're often then having to be placed in a nursing home. And I think that we could do better if we really were concentrating on how important it is to get people functioning up and ambulating, transferring, toileting, and really maximizing our efforts to their benefit.
Good morning, Mr. Howell.
Good morning.
I'm Jessica, your nurse today. You
Glad to know
remember
you.
me?
Yes, I do.
Good, good. Well, today's the big day. Get to go home.
That's right.
Yeah. How do you feel about that?
Wonderful.
Wonderful. I bet you do. You've been working really hard in
That's
your
right.
rehab after your hip surgery that you had.
That's right.
Yeah. So today I'm going to just ask you a few questions to learn a little more about your activities of daily living,
All right.
so that I can bring it back to an interdisciplinary team and we can make sure we have the best discharge in place for you.
All right.
Okay? I also have two nursing students with me.
Uh-huh.
This is Abby and this is Sam. And is it okay if they're here as well?
It's all right.
Okay. Earlier today, this morning, when I was assisting you in your shower and some toileting, I noticed that you were using grab bars to help you.
Yes, I would.
Okay. Is it because your left hip is still weak?
Yes, it is.
Is it painful?
Yes,
Okay. And do you find that the grab bars are helping you?
that they are.
Okay. Mr. Howell, when you go home, do you have grab bars in your shower toilet area?
No, I haven't.
No, you don't. Okay. What about stairs?
I have a number of stairs.
You have a number
Three
of
stories.
You have 3 stories of stairs.
That's right.
In your apartment?
And,
To get to your apartment?
and the building where
Oh.
my apartment is located.
Okay, now do those have grab bars though?
No. Oh, yes. Yes,
Yes, they
have.
do.
They-
Okay.
they
Okay.
do, on the stairways.
Okay, and will you have help with you? Do you live with anybody, Mr. Howell?
No, it's just my son.
Your son, will he be staying with you?
Until I recuperate.
Okay. Will he be able to help you up the stairs?
Yes, he will.
Okay. Okay. I've also noticed that you've been able to use your call light here in the hospital to help for toileting. And the nurses come in and help you? Is that correct?
That's right.
Okay. Do you have full control of your bowel and bladder?
That I do.
So we have no concerns there, do we?
No.
Okay, good, good. How is your mobility? How are you moving around?
Well, it's not quite up to par.
Not up to
as
par?
yet.
Okay.
Yeah.
I would like to see you get up and walk around a little bit. I want to see how safe you are on your feet. Do you use a walker or a cane at all?
Okay.
A cane, okay. So we are going to grab your cane over there and help you get up, okay? Will that be all right?
All right, I will show you.
Okay, good. Abby, if you can grab this cane. So, Mr. Howell, so you bring your feet down. Okay. How you feeling?
Good.
All right. If you want to just kind of walk back up to that wall and back. You're doing very well. If you want to have a seat here. Great. How did that feel for you?
Wonderful.
Good, good. Now I'd like to see how you get out of a chair. All right. I can see you stand up again from the chair. Okay, and you can go ahead and have a seat on the side of the bed again. So safety is a big issue after a hip replacement surgery. But you're doing very well
Good.
walking. And are you dizzy at all when you're
No.
mobilizing? Okay. So now I'd like to observe you getting dressed to see if you need any help with that. Will that be okay?
So that.
I'm going to grab your clothes for you. Okay. So Mr. Howe, how will you be getting home today?
My son will be picking me up.
Your son will be picking you up. Great. And he'll be taking you into your home? Helping
My
you?
son.
Okay, good. So there's your clothes, and I like to observe you get dressed.
All right.
Okay?
All right.
Okay. You did a great job getting dressed. I noticed that you did need some help with your shoes. Tying your
That I
shoes?
did.
Okay.
That I did.
Okay.
The left shoe.
Your left shoe. Okay. So do you have any questions for me, Mr. Howe?
No, I haven't. Not
Okay.
at this moment.
Well, I will be back again as soon as your son gets here to do the final paperwork.
All right.
Okay, and you're looking very nice to go home. Very spiffy.
Good.
Okay. I'll be
Nice
back
meeting
in
you.
when we're all ready.
All
Nice
right.
meeting you.
All right.
Nice meeting you.
All right. It's nice meeting you too.
Well, I did perform the activities of daily living for Mr. Howell, and I had the two nursing students, Sam and Abby, do one as well. So I'd like to compare our results if we can, and we can just go step by step down the list. We'll start with bathing first, and I'd like to hear what your assessments are with bathing.
When talking about bathing, I was a little bit unclear about how you helped him. Could you elaborate more when he was taking a shower this morning?
Well, when I said I was assisting him earlier in the shower, what I had to do was just kind of wash his back. He was unable to do his back because he had to hold on to the grab bars. He was able to wash the rest of himself holding one grab bar at a time. But he was unstable to be in the shower alone, so he did need to hold on to those. So I actually scored Mr. Howell a 0 in that area. So the next one is dressing. Okay, and what did you both score on that one?
I gave him a 1 since he was able to dress himself, but only had issue with tying his left shoe.
Okay, Sam?
I also scored him a 1 because it says in the Katz score that they may need help tying shoes, and that was his only disability in that area.
Right, he was able to dress himself very independently.
Other than that, yes.
And he was able to tie his right shoe but not his left, so
Right.
we will discuss that for his discharge. Okay, and then toileting. Let's talk about toileting.
I gave him a 0
Okay.
since he needed help to get on and off the toilet.
Okay. And Sam?
I also gave him a 0.
Okay, good. I did it as well. And yes, he needed help with the grab bars and using the raised toilet seat right now because of his hip surgery. Okay. For transferring,
I gave him a 1.
a 1.
He showed us that he was able to transfer from his bed to the chair using his cane.
Okay. And Sam?
I also gave him a 1 on that as well.
Good. Yes, because in the Katz tool, you can score a patient a 1, even if they do use an assistive device, and in his circumstance, it is a cane. So, very good. And then for continence?
I gave him a 1 also. He confirmed that he was continent.
And then for feeding?
I gave him a 1 also. He, by looking at his tray, he showed us that he was able to eat by himself without help.
Same?
Same, yes.
Okay, very good. Yes, I scored him as 1 as well. He is able to feed himself without any difficulties. Okay. Any questions about the Katz tool at all?
I did have a question. I was wondering, what is the cutoff? At what point do we decide, at which number do we decide that the patient needs to stay in the hospital and they're not safe to go home to complete their activities of daily living?
It's difficult to say what the cutoff is because it depends on what the person's deficit area is and where they're being discharged to. So, for example, in Mr. Howell's case, he has some significant things that need to be dealt with. He has a lot of stairs to deal with. So that if it was unsafe for him to transfer, we'd really be concerned about him being discharged. So even one ADL deficit for him would be troublesome. given the type of living environment he's in. But if it was a person that was returning, for example, to assisted living, and they were going to have a lot of home care help and family help, we actually could have them return to home with even 4 or 5 deficits, so that it depends on where they are going to be discharged to and how much help they're going to be getting. Now, 3 is considered moderate dependence, but again, going back to the fact, how much help do they have once they're discharged? If they have no help, then it depends on which ADL is troublesome or problematic, so that they can be safe at home.
What we're going to do in about a half an hour is meet with the interdisciplinary team. That's going to include the physical therapist and the occupational therapist, and Mary will be there as well. And we will bring our feedback and our assessment to the team so that we can all sit together and have the best plan available for Mr. Howell on discharge. And then after that, we'll go in and see Mr. Howell again and give him the plan and update him on his discharge.
So from an occupational therapy perspective, we've been really working on obtaining the equipment that he's going to need. So he will be taking home an elevated toilet seat that will be delivered today. And his son has arranged to have some grab bars installed. So I think the bathroom situation will allow him to be independent in that setting. And we will have his son watch how we do that here when he comes in for training this afternoon. The other thing in terms of the shoelacing, we've been working on that very diligently, and so what we've decided and what I've talked to the son about with Mr. Howell as well is that there are 2 options, either using elastic shoelaces or getting slip-on shoes and using a long-handled shoehorn. And we've tried both of those, and we'll demonstrate this today with Mr. Howell's son when he comes in, and they can make a decision, and we've provided them with resources. So I think from an occupational therapy perspective, he won't need our services anymore after discharge today, and I see him being in an independent level in those skills.
From a physical therapy standpoint, Mr. Howell has progressed quite well with his ambulation and as well as with his therapeutic exercise program. He's advanced to using a cane, which is still below his baseline, but he will be able to manage well enough at home with that. He will need to continue gait training at home, and that can be provided through home health physical therapy at this point. His son will be able to assist him on the stairs, but the home health physical therapist can also assess him on the stairs when he gets to be in his home environment and make sure that his son is doing that appropriately and correctly. Mr. Howell is familiar with his therapeutic exercise program that he will continue at home. We will go over that with his son this afternoon so that he's aware of that program and can assist Mr. Howell as necessary. So we will continue with home physical therapy at this point, and that therapist can determine when Mr. Howell is appropriate to transition to outpatient physical therapy if necessary. Should we be concerned about the fact that he has to climb 3 flights of stairs to get to his apartment? That's a very good question. Actually, we've been working on stair training with Mr. Howell quite a bit. He's done quite well with that, using a handrail on one side and his cane that he ambulates with on the other side. We will this afternoon go over stair training with he and his son so that his son feels comfortable with that process.
I had a question. You were talking about the elastic shoelaces. I was curious how that helps Mr. Howell get his shoes on. How exactly do those work?
Well, as you know, Mr. Howell is not able to bend beyond the 90 degrees, so he can't bend down to tie his shoes. So what this does is that the elastic shoelace provides a way to keep the shoe tight at all times, but when he slips his foot in, it expands like with elastic. So it turns into more of a slip-on shoe, and the long-handled shoehorn just helps the foot slide in a little bit easier.
Well, I think that we can all agree that Mr. Howell has been a big success story here. He only has the deficits in the areas where he needs some help with toileting, and it sounds like the adaptive devices and the raised toilet will answer most of that difficulty for him. It'll address it. And then the occupational adaptation for his shoes will make him independent over time in his dressing. So I think given that and the fact that he was independent at baseline, that probably with his physical therapy progressing forward in a positive way, We're looking at probably full recovery for Mr. Howell, and it would be nice then we can see him back here and back on his feet without his cane. Full recovery and a good success story. The factors that affect functional ability in older adults are multiple. Oftentimes, for example, osteoarthritis is extremely prevalent in the United States. So that can, over time, cause people to lose their function in their mobility and able to transfer, able to bathe themselves, getting in and out of the bathtub or the shower, getting on and off of the toilet. So osteoarthritis is a chronic condition that can cause, over time, a loss of functional ability. But there are other things that can cause acute loss of functional ability. So, for example, the most common one being a fractured hip. So someone is walking in their home and they slip on a rug and they fall and fracture their hip. And again, they're in the same situation as the person who has arthritis. They have difficulty getting in and out of a shower or a bathtub. They have inability to get on or off of a toilet, so that they also have problems then with their functioning. Medical problems can also cause a loss of function. So, for example, a person has a stroke who may have a left or right-sided weakness, oftentimes has a disability in one of their areas or activities of daily living. For older adults in the United States, losses in activities of daily living are more prevalent than I think most people realize. So, for example, in community-dwelling older adults, for people between the ages of 65 and 74, 13% of men report at least one deficit in one activity of daily living, and 20% of women between 65 and 74 report at least one activity of daily living loss. For older adults over the age of 85, that number increases dramatically. 35% of older men over 85 have reported one ADL loss, and 58% of women over 85 have reported one activity of daily living deficit. In institutionalized older adults, 97% of them have at least one activity of daily living deficit. The Katz Index is a quantitative assessment tool that measures 6 areas of functioning for activities of daily living. It scores the person as dependent or independent. And inside this tool itself is descriptive language to assist the evaluator in whether or not to score them independent or dependent. And for that reason, it's a very easily administered tool. And so there's many adaptations of it, and there's some tools like the MDS in long-term care that have the factors in the Katz incorporated into their assessments. In acute care, I think the Katz should be done every day. And the reason for that is that we want to measure the person's improvement or the decline. We want to take a look at our care strategies, and if the person's declining, we need to readjust those care strategies. And ultimately, what we're looking at is to make sure that we maximize their recovery so that they can have a safe discharge to home. One thing I'd like to point out about the Katz ADL tool is that if the person refuses to do the activity, they are scored as dependent. And that can seem confusing to people because they look at the person and they say, oh, I think they can do that. But the Katz relies on direct observation. And if a person refuses, there may be many reasons that they refuse. They may be depressed. They may have a confusional disorder, such as Alzheimer's. But the bottom line is that we don't know if they were able to do this activity safely or not. One of the most serious challenges for administering the Katz assessment tool is for persons who are confused. Oftentimes they have the ability to get on and off the toilet independently, but they cannot follow commands. So administering the tool can be very challenging with this particular population. Another challenge is that in acute care, oftentimes we don't have the bathroom facilities in order to evaluate whether or not a person can be independent in showering or bathing. And the same is true in long-term care. Oftentimes, they require staff assistance because of the type of bathtubs or showers that they have. I can give 2 examples of patients that I've had difficulty in evaluating. I had an elderly gentleman whose wife had died, who was living at home by himself and was independent, and he had been admitted to the hospital for pneumonia. So I needed to know whether or not he could safely toilet himself. But this was a man who was so embarrassed to have a young woman come into the bathroom with him, and he couldn't understand, even when I tried to explain to him, because of his hearing loss, why I needed to watch him get on and off the toilet, why I would want to do something like that. So this was very embarrassing for him. I also had a woman who was of another culture who was very shy and modest. And she was very embarrassed, and because she was confused, I also couldn't explain to her why I needed to be with her while she was showering and dressing and on the toilet. I think, again, it goes back to the skill of the clinician to dress the person modestly and to adapt the environment in a way that the person can toilet themselves and shower themselves and still not have to expose themselves. Again, in some religious belief systems, it can be very difficult, so you may have to be very careful about the gender of the healthcare provider who is assessing and observing that patient. In acute care, I think that nurses are getting better at assessing functional ability because they see that in order for a patient to return safely to their discharge environment, the nurses need to have that as part of their assessment so that they can plan for a safe discharge and plan the interventions needed for the person to return to the community. I think one area where functional ability is not assessed adequately is for persons living in the community where nurses may or may not have a sustained contact with them. So I think there are many older adults who become deconditioned over time because they think it's a normal part of aging. And rather than laypersons and nurses in the community knowing that this is not a typical pattern of aging that is irreversible, that they could actually go and help out very much by looking at deficits that people are experiencing, trying to determine what are the causes of those deficits, and helping them intervene to, again, maximize their abilities and to increase their quality of life and independence. Another area that I think actually that we could do better with functional assessments is in clinics. I think that clinic nursing is a very, very important part of nursing, especially as we have an aging population. In many cases, other than the ER, the clinic is where we see these patients day in and day out, people in their 80s, 90s, and even 100-year-olds. So I think a clinic nurse is very critical to assessing a client or a patient and saying that they see some difficulty in transferring and getting them to a physical therapist, getting them some occupational therapy at home. There are many reasons to get a baseline assessment for the person's activities of daily living. The first being that we need something to compare subsequent evaluations to. So when a person comes into a hospital, for example, we need to know what their abilities to do their activities of daily living are. Then when we do subsequent assessments, we can tell if they're getting better or worse, because actually it's easy, as I said before, to get worse in a hospital. So that those type of what we call serial assessments over time can allow us to gauge whether a person's getting worse or better. The best resources that I would recommend for persons that are interested in more information about the Katz Index of Activities of Daily Living is the companion article in the American Journal of Nursing. And in that article is more details about the Katz Index itself. The second resource that I would recommend is found at the Hartford Institute for Geriatric Nursing at New York University's website.